Hello and welcome to our webinar Wednesday about occupational therapy and cancer care. April is Occupational Therapy Month, so we wanted to highlight this aspect of cancer care and where occupational therapy fits in on the cancer care continuum. Just as a reminder, please mute yourself when you're not speaking for those of you who are joining us on Zoom. This is being streamed live to Facebook and is being recorded, and the video will end up on our YouTube page as well. So feel free to turn off your camera if that makes you more comfortable. If you have any questions throughout, please use the chat box. You can direct message them to me or ask the group if you're comfortable with that. For those of you who are joining us on Facebook Live, please feel free to use the comment feature to ask any questions or comments that you may have throughout the presentation. Webinar Wednesdays are a program sponsored by the University of Chicago Comprehensive Cancer Center, Office of Community Engagement and Cancer Health Equity. My name is Aaliyah Poulos, and I am an education outreach specialist in this office. We're also joined today by my colleague, Erica Rodriguez, who's our Latinx outreach specialist. And our job is to bring cancer-focused education to the greater communities that we serve across Chicago and beyond. So we are thrilled today to have you all joining us from various communities in and around Chicago, both within the University of Chicago as the institution and outside. So thank you all for joining us today. We're happy to bring this educational programming to you. Our speaker today is Catherine, or Kate Aronson. Kate is an occupational therapist in the Center for Supportive Oncology at the University of Chicago. She has a master's in occupational therapy and trained at the University of Chicago Acute Care Fellowship Program. She's board certified in physical rehabilitation and a member of the American Occupational Therapy Association, and we are thrilled to have her here today. So I'm going to stop this presentation and oops, let me stop sharing my screen for a second, and I'm going to pull up Kate's slides here. And okay, I'll share my screen again. Okay, hopefully you can see this okay. Okay, Kate, take it away.
Awesome. Thank you so much for, I think, working through our technical difficulties here. Thank you so much for having me. Yeah, of course. Again, if anyone just wants to stop me throughout, if you have any questions, I like that you found my grad school picture.
Do a little internet searching.
Yeah, perfect. That is me. But yeah, so yep, I am an occupational therapist. Has anyone here had occupational therapy before? Totally fine. Does anyone here know what occupational therapy is? If not, you're in the right place. But yeah, before we really start going, a little bit about me. I work at the Center of Supportive Oncology. I also work on the inpatient side in the CCD. So luckily for me, I guess I see the whole spectrum from anyone who is coming in for their diagnosis to survivorship. So it's never a dull day, constantly learning. But I'll try to stay as focused as possible and then kind of start broad with what occupational therapy is, and then kind of taper down into OT and cancer, and then give kind of some patient stories as well. So then I'm kind of also looking off of my screen real quick. If you could go to the next slide, that would be great.
Is this the slide you want?
The next, so if you can go into like play slideshow, like without the notes.
Oh, can you see the notes?
Yeah.
Oh, like, okay. You know what? On my end, I can't see the notes. So let me go ahead and let me restart this. Thank you everyone for your patience. Let me figure out. Yeah, I can't see the notes. I can see the captioning that we have, but let me try this again.
Okay.
So
otherwise I can see if I can share my screen as well. Oh, okay. I think it does work. Maybe I was looking at it from...
Can you see the notes right now?
No, that's perfect.
Okay.
Okay, great. All right, so we'll just start off with what is occupational therapy? So if I go down to the definition from the American Occupational Therapy Association, occupational therapists and occupational therapy assistants are healthcare providers who specialize in helping individuals across the lifespan participate in society and perform their most valued occupations, regardless of whether they have illness, disease, or disability. So I italicized occupations because what is occupations? A lot of times people will be like, occupational therapy, like I'm not working right now, I don't need you. But occupations truly are what occupy our time, you know, the everyday activities that we perform throughout our lives from waking up to going to bed. So I kind of like to see myself as an occupational therapist as that problem solver, finding that something that gets in the way of anyone doing what they want to do, have to do, expected to do. And then we as OTs then help that individual identify that barrier and either adapt the activity, adapt the environment, or help the person in order for them to feel successful. So you'll kind of see in that diagram, that picture, at the very center is the person, and that's the true integrity that we're trying to maintain, that they're successful, they're feeling independent in any meaningful activity that they want to engage in. So that could be something as simple as ADLs you see on an outside ring, like dressing, bathing, grooming, IEDLs, so it's more like grocery shopping, cooking, cleaning, but the whole spectrum of waking up and going to bed, rest, sleep, education, work, play, leisure, all of that is something that holistically we're looking at as an occupational therapist. So then going back to even like the central part where you have person, each person is made up of a lot of different client factors, being body functions, whether your mental functions, your sensory functions, your neuromusculoskeletal and your movement related functions, cardiovascular, respiratory, those as well as body structures like your anatomy in terms of organs, limbs, joints. When it comes to cancer and cancer treatment, 100%, a lot of times these areas are affected, challenging even people's values, beliefs, spiritualities, as they do face a life-threatening disease at times. So it's nothing that we aren't ever addressing. And then treatment and cancer itself will affect the body and its functions and structures across the cancer continuum. So with our background as an occupational therapist, we're able to safely progress people dependent on their individual situation. Also in one of those bubbles is performance skills. Those are goal-directed actions that you can see as they like are trying to go through their life and their occupation. So that's like motor skills, cognitive functioning, processing, social participation skills. Again, cancer and its treatment can impair strength, endurance, range of motion, cognitive processing time, and decreasing social interaction. So other things that, again, is underneath our purview, our domain. One last thing that I also want to talk about in that center is your performance patterns, habits, routines, roles. 100%, a lot of times people will identify themselves as an employee and their routine of work is then drastically changed because now that's transitioned into more of a routine of consistent doctor appointments. So how do we then find that something that's getting in the way of participating to their fullest ability and then helping them feel successful? So if you go to the next slide. Perfect. I keep up too. The occupational therapy process, again, we focus on the relationship between the patient and his or her environment, task, personal factors, and address any gap that in participation in order to facilitate that meaningful independence via occupation-based activity. I'll go deeper into that as we go, but it starts off with a client-centered evaluation. Then as we set our goals, identify what the gaps might be, then we target those goals and those gaps in intervention sessions and treatment sessions, and then task modification to facilitate that progress towards their performance-based goals. It begins with identifying what the client needs, wants to do, and supports any barriers to participating in those activities. It involves an analysis of pre-cancer participation in ADLs, IEDLs, functional mobility, their roles, routines, and also just a likelihood of resuming them, given any, our expertise as a therapy in the cancer realm. it takes some experience for sure, and using a multidisciplinary approach with a lot of our care providers. Factors also such as home environment and potential need for adaptive equipment or modifications for safe driving, inter-community building or mobility are what we support and address as well. And then following evaluation, a plan of care is developed and maintained until those goals are met. And then the next slide focuses a little bit more on the OT intervention and specific services that we provide. We provide self-care, like training and self-care activities, bathing, dressing, adaptive and durable equipment, and compensatory strategies if needed. Splinting, positioning, training family and caregivers to assist in any maybe range of motion exercises, safety with transfers and mobility, skin checks. We use neuromuscular reeducation, trunk stabilization, balance activities to improve maybe the client's ability to get out of the bed, maintain an upright posture, balance functional ability necessary to be able to complete your self-care tasks and home management activities. We also use relevant occupation-based activities and preventative splinting to preserve muscle balance and range of motion for functional tasks, address cognitive and perceptual deficits, including compensatory strategies and techniques, and contribute to safe discharge planning, including recommendations for transitioning to the next level of care. And in addition, training patients in pre and post surgical orthopedic protocols, including anything appropriate with like weight bearing or precautions during any of their ADL tasks. So that's a little bit broad overview of everything OT intervention related. Now with the next slide, we can just kind of think also broadly just about the cancer experience. The true role of an occupational therapist is to improve a person's quality of life through all phases of treatment and beyond. Now that we've had so much more research and new treatments and really exciting things, people are living longer, but with living longer, they're living longer with what's now more of a chronic disease. And with that, you're going to have different deficits that 100% occupational therapists address. So all throughout this continuum is where you might meet an occupational therapist, from prevention to end of life. So if we circle back to, and I'll go to the next slide, the individual, there is truly so much more than just that kind of chart that I had originally started off with. Yes, you have like individuals' work, life, leisure, family, but also their psychosocial well-being and treatment, disease, and the side effects related to that. So just taking that individual, and then if you go to the next slide, superimpose what could be multiple different cancer-related impairments, weakness, lymphedema, fatigue, balance deficits, chemo-induced peripheral neuropathy, things just get a lot harder, right? And truly a barrier to be able to do the things that you want to do, have to do, and expect it to do. So then when it comes to then that individual seeking and having occupational therapy, there's a few different lenses that we can approach. So depending on the individualization of this patient's care, the next slide is where you might see kind of where our thought process is and our clinical reasoning is as an occupational therapist. Are we helping that person prevent any issues? Are we helping restore? So are we targeting some and improving some deficits such as balance, for example? Are we with like exercise? Are we adapting? Are we like using more compensatory strategies? If for some reason we feel like because they're going through active cancer treatment, they're going to have this fatigue, they might have this pain, what are some things that we can do to the activity or the environment to make it more meaningful and successful for them? Or is it palliation? Is it more comfort? Are we training family on how to safely and ergonomically transfer their loved ones, or equipment to make things easy so they can still feel as participatory in their ADLs, something as simple as a bedside commode so they can still do their toileting, but they don't have to go as far as the bathroom itself. So we kind of work not only with the patient, but with the family, and then we're always transitioning and recircling back to goals that make the most sense and are also most meaningful for the patient. So the next slide, still in regards to rehabbing cancer, Again, there's a lot of areas that you might see an occupational therapist across the spectrum. So in acute care, they might recommend that someone gets acute rehab or subacute, or recommend outpatient or home health. This is where still we're working with patients, we're just addressing any deficits that they might have. It's always a multidisciplinary team kind of aspect. You've got physical therapists, oncologists, pharmacists, social workers, nurses, child life specialists, speech language pathologists, chaplains. So it's very highly interdisciplinary with a lot of communication, which I think is really great in terms of holistically helping this individual with anything that they might need. So in that regards, if we're just focusing more on maybe the outpatient spectrum in this circle, I'll go to the next slide and kind of, circle back to the process again. So we have an individual who is recommended for occupational therapy for an evaluation and treatment. So we start with that evaluation, blend on down to an intervention and targeting those outcomes while still acknowledging a few other elements, given our therapeutic use of self is something that, for those of you who might not know what this is, it's the therapist is able to modify how we interact in order to make to help the patient be most successful. So if there's someone that just needs direction, like you just got to tell me what to do, and that's kind of how they would like to be guided. Or if it's someone that you need to support them through a lot of their decision making, it's kind of something that we are able to hone in and out of depending on how the patient is that day. Activity analysis throughout, either grading up or grading down an activity in order to meet their occupational participation goals, and then clinical reasoning skills throughout. So now I'll go through a patient story. So I made up his name. His name's not actually George, but George is a 56-year-old male with glioblastoma, diagnosed with a glioblastoma in January of 21, now status post tumor resection and currently undergoing outpatient radiation. Consulted for outpatient occupational therapy evaluation and treatment at the CSO. And a lot of what he had been reporting was cancer-related fatigue, weakness, impaired cognitive processing, poor sleep, and balance deficits. So the next slide kind of looks a little busy, but I'll kind of go through it broadly. It's just to kind of tie it all together, where we're looking at first his occupational profile. So I'll be sitting down and having a conversation with him on how his prior level of function was. What was it like before January? And he was independent in his ADLs, IDLs, functional and communal mobility. He's retired and likes to walk with his significant other, and he likes to read the dictionary and learn a new word each day. So he's always like texting his friends different words. But truly, when I got down to then talking to him and how he's doing right now, he was seeking OT because he was just feeling tired all the time and difficulty concentrating. He was veering when he was walking in the community. He had a hard time doing some of his chores, like walking to the grocery store, which he really enjoyed. And he just really wasn't even having enough energy to like even shower. So on that first day, the evaluation, kind of taking the analysis then of his occupational performance, his client factors. So in terms of his body function and structures, we'll end up using objective things and tools and assessments to be able to put subjective things into, whether it's numbers, whatever, but things that we can track so that we can, definitely have some concrete things to demonstrate change and progress over time. So for him, his MMT, his manual muscle test, he was like 4/5, 5 out of 5 is the best overall. So not terrible. But he subjectively felt weak. Hand strength was fair. His balance, he needed supervision. Like he walked in with a significant other and like he usually holds her hand to help him from veering. He wasn't really able to walk more than 4 minutes when we were walking, and I was timing him before he needed to like take a break. And I also gave him this assessment tool. It's the Brief Fatigue Inventory, BFI. and in all categories, and all the categories kind of span throughout, and anything from, you know, very simple things like getting dressed to very high level things. He was reporting like severe 9 out of 10 fatigue in all these categories. Performance skills, like his gross motor and fine motor, not great. Sluggish. He does have expressive speech deficits from the surgery itself and where the glioblastoma was. So he is seeing outpatient speech therapists as well. He had mentioned his processing speed was a little off, so I gave him the MoCA, which is a cognitive assessment, and he scored fine, like within a normal range. I really did, and after kind of teasing this out with him a little bit more, a lot of his cognitive processing and attention deficits were related to his fatigue. So just in that way, we're using these objective measures to really kind of fine tune what the true issue is and how to best address it. And then his roles, he really, you know, identifies with being a friend, texting his friends, his dictionary names, or like any words, his significant other. He prides himself on managing his personal finances. So without having that concentration, it was really hard for him. And he's retired, he's leisure based. So like knowing that, you know, how am I able to like kind of embed some treatment ideas, some homework for him in his routine, and what's going to give him the most carryover if we're actually doing them or not. So that's where we kind of get creative as well. One last thing to kind of note on in terms of when you're looking at a person is what's their context, what's their environment, culturally, temporally, personally, virtually, even like the terrain that he's walking on. Is how I need to always kind of keep that in mind too, whenever providing interventions to make this a lasting improvement for them, so it can actually help. So after kind of the analysis of his occupational performance, we go through, like I have goals in my head, but 100%, the goals won't make sense if they aren't meaningful or make sense to the patient. So we just started with 5. I thought like bathing, and I asked him this too via the shower. I was like, is this like, he rates, and then I gave him kind of like a sheet and assessment to rate like his most important things, and showering was high on there. So one of like an OT goal that you might see is, you know, he'll complete bathing via a shower chair, like a bathing via shower, MODI or modified independent, with the use of an appropriate assistive device. He'll independently verbalize and demonstrate 3 energy conservation techniques embedded in an IADL of choice. He'll complete a fine motor coordination, gross motor coordination, home exercise program independently, so that he's improving his strength for the function of improving his functional mobility and ADL routine. I want him to be able to demonstrate community ability with MODI, because it is so important for him to be doing a lot of the things that are higher level activities, like going to the grocery store, doing any chores he needs, or just going on a walk. And then independently verbalizing and demonstrating some concentration and attention modifications to improve this cognitive processing. In general, he's pretty high functioning and very introspective. I didn't think I needed to see him every week, but that's part of my clinical reasoning skills. Again, I also, thinking about his context, I know that he's already coming in for appointments every 2 weeks. He's got speech that he comes with. So I didn't want to unnecessarily bring him to outpatient sessions if it was going to be another burden on his routine. So made sure I coordinated that with him as well. And we kind of got on a good routine. So the next slide is then going into the intervention. So those were the goals. Those were thinking about, this is what I actually did with him. So to address his balance and weakness, if we think about that one chart that I gave you with restorative, adaptive, palliation, there's a lot of things that we can restore, but there's a lot of things adaptively that I feel like we could give him as suggestions to improve his participation like immediately. So for example, with his balance and weakness, we worked on therapeutic exercises and treatment sessions, and I individualized a home exercise program for him as homework, gave him a kind of, I think, a good frequency and amount of times to do each rep. We went through it. He showed me. He had maybe like a few cues to give him for form or pace, but overall very good at, return demonstration. And I was like, do you have a cane laying around? Maybe that might help you instead of holding your significant other's hand. So we practiced with using a cane and some anchoring techniques for his veering. I asked him, I'm like, are you kind of like looking around your environment when you're walking? If so, like, it might make it harder. So choose one point in the distance, whether it's a building, a tree, but like keep that as your focal point so that if you find that that thing is moving, then that means your body is probably veering. So that was an education point I gave him to try to work on to address his cancer-related fatigue. I think restoratively exercise, research has shown that exercise is one of the most important things that you can do to improve this fatigue. It's just really hard. So I didn't want to like overburden him and make him feel bad if he wasn't doing his exercise program. So I gave him something that he already enjoyed, and it was going for walks with his significant other. So whether he was doing it one time a day, a few times, at least one time, get out there, see what you can do. And then if you need to take breaks, that's fine. So a light exercise program of walking, energy conservation techniques, fall prevention strategies, work simplification techniques, and then equipment. So I suggested a shower chair so that he can just sit when he showers. So he's like able to conserve some of that energy and be able to still complete the task without kind of being exhausted for the rest of the day. And then his cognitive processing, which really is part of his cancer-related fatigue, I gave him some concentration techniques and just ways of reducing stimulus so that he's able to participate. So he had mentioned that he definitely get overstimulated at times. So I just gave him the simple suggestion that throughout the day, pace and give yourself maybe these opportunities to go into a dark, maybe like no noise, or at least quiet noise, like just quiet, dark. You can close your eyes, you can meditate, just like recenter yourself. And he said he had started doing that, and it really did kind of help with being able to then focus for the next task that he was doing. So the next slide kind of goes over that after the 2 weeks, that next treatment session, he had implemented a shower chair. He like really enjoyed that. That was great. So if there was a day he wasn't feeling great, he sat. If it wasn't, it's fine. He was able to verbalize some energy conservation techniques that he was embedding within his routine, but I kind of wanted to keep that on in order for it to be something that we keep revisiting. For the home exercise program, again, another thing that I wanted to keep revisiting just so that he didn't have any fall off, and or modifying to make it even more challenging if he needed that or not. And community mobility, he came into that next treatment session with a cane without his significant other, and he then also gave me some self-report that the veering was improved with just kind of using some anchoring techniques. And then the last one was about concentration modification. I think he had like another one that was really good. So like he also was really good at then taking what I gave him and thinking creatively in his routine, there was other suggestions that I had given him that he was like, oh, I can also do this, for example. So he had already implemented some good kind of pacing and cognitive strategies, which was great. I wanted to give him another goal for the next time because he was still having a hard time with being able to, for example, he wanted to take his like wool blanket to the dry cleaner, but like it was really hard getting there and back. So like something that he's really wanted to focus on is his activity tolerance, his endurance. So we kind of added another one to the mix to be able to engage in at least like greater than or equal to 10 minutes of light exercise walking without a break, in order to improve his endurance for being able to do those things, his IADLs and community mobility. So on to the next one. Thank you. I don't know if I rushed through that or not. I feel like in the moment.
You're great. You're great.
Does anyone have any questions? I've got like my references on the next slide, but yeah, any questions at all?
I'm going to actually stop sharing my screen so I can just monitor some of the any questions that might have come through the chat box.
Mm-hmm.
I wrote down a question that I have, and I'm seeing that someone else has the same question here. So one of the and this is sort of a question that I don't know that I can fully answer, though I know it a little bit better that now that you've explained this, but can you describe or explain the difference between physical therapy and occupational therapy?
In my head when I was making this, I was like, do I make a slide? I think I anticipate this. Yeah, for sure. No, I think if you think about physical therapists are looking at like how you're walking and your gait pattern and that kind of essence of it. And occupational therapists are looking at what you're walking to. So a lot of times we are addressing their balance, their strength, their endurance, but in terms of more globally, the activity that they're doing. So I might be able to cue someone on different techniques to be able to improve their balance or endurance, but I'm not necessarily going to be like gait training them the way that a physical therapist might. On the outpatient side too, they've got a whole slew of certifications and specificities where they're able to kind of like do certain types of tests to figure out what is causing your pain or what is causing maybe your gait imbalance. But from an occupational therapy standpoint, we're looking at kind of like your engagement in the occupations and what's getting you from doing that. As a physical therapist is looking at what you're walking basically.
Okay.
That help?
And it's just that's always been one of those things where I'm like, I don't know that I could quite articulate that, but that's a lot really well explained.
I hope so. Thanks.
So the gentleman that you described in your case study there, would you say so I guess the issues that he has, is he more of a common case? Is he more of an extreme case? Like what are some of the issues, with the more common issues that you would see for patients?
On the outpatient side, I do see a lot of like chemo-induced peripheral neuropathy as well. That's a lot of times really something people struggle with. Their hands, their feet, if they're just not feeling their feet in particular the right way, then balance is for sure definitely a deficit and something you want to look at, but also like falls. So we as occupational therapists do a lot with education with fall prevention. So that there isn't an issue that then precipitates after a fall. So I'll see a lot of just sensory deficits in that regard and fatigue. And for him, yeah, he is someone that I think encompassed a lot of those general issues that I might see on an outpatient side. I also wear the hat of the inpatient side as well. So that's like a whole different probably field or answer. But for the most part on the outpatient side, it's these type of chronic things that are really kind of just really getting in the way of someone wanting to do what they want to do, I guess.
Okay. And then can you just explain the process a little bit? We've had other speakers from the Center of Supportive Oncology speak on our webinars, and it's just really it's awesome for us to see because cancer care is so broad, right? And so we know a lot of the clinical things, what a physician does, but hearing about what a nutritionist does and what a social worker does is just really important to grasp like the full complexity of the cancer care continuum.
Right.
And so can you just describe a little bit about how you work with, a nutritionist or a social worker? How do you all work together to get a complete and holistic treatment plan for your patient?
I think a lot of times I'm doing quite an extensive chart review so that if there is something that I'm noticing, like you said, it's just such an experience and it is encompassing so many people that I feel like with everyone's heads in the game, it really can make a true difference. So I'll usually reach out or we have rounds. So we'll listen to daily rounds, whether it's me, myself, or a coworker. So that at that point, that is our opportunity to have a lot of different people on one call necessarily. And if it's not run by me necessarily, but that's that moment when if there's a patient who's brought up and you might have like a question about, then that's like for sure your opportunity to kind of have that collaborative experience. For example, even with this gentleman that I talked to you about, I was in the same room as a physical therapist and there was a and I was in my head as it was like, I think the first evaluation, I was like, he probably would benefit from PT as well. Not that I want to like add another practitioner that he has to come into but it could be worth it. if he is having more of a veering problem from a gait issue as opposed to a veering problem from like a cognitive or attention or fatigue issue. So at that point, I was able to just reach over to Tom, our PT, and see if he had any availability for him in his appointment. So I think the onus is on me for sure, but I reach out the best I can by either kind of really sifting through their chart, having these conversations on rounds, and then also just the close connection we have with our physical therapists in our department.
That's great. And so I guess, how does a cancer patient get to you? Are they referred out from a physician?
Yeah, and for this situation, it was unique for me because he did have his surgery here on the inpatient side. So a coworker of mine was in the neuro ICU had evaluated him, so I could kind of see, at least in writing, throughout his trajectory from the ICU all the way to me. So then at the acute care, on the inpatient side in the CCD, she recommended outpatient OT. And then that process then brought him to my door. So whoever then is writing from the physician to get referrals, then that was how I ended up meeting George. But yeah, so it's a script that is written for the doctors to me.
Okay, that's great. So they're ushered then from every point of cancer care.
Mhm.
And then I just have a couple of personal questions for you. What would you say is the most challenging part of your job, and then what's the most rewarding?
Oh, the most challenging. I feel like, because I think there's so many things that are so occupational therapy. I look at someone, I'm like, oh my gosh, there's so many things, because we have such a holistic profession that I always in my head, I'm like, oh my gosh, I could always do so much more. And I think about it, even for example, George, he had an appointment a half hour after seeing me. So it's my most challenging thing is making sure that, in the time I have, I'm really focusing on what they need to focus on. And I think that's something that I've done better at for sure. But I think also another struggle is probably just the fact that I do inpatient and outpatient. So the volume of patients I have sometimes is a challenge, but that doesn't go without just being, organized and making sure you're doing your thorough chart reviews, for example, making sure you're reaching out to those care providers where it makes sense. So that's probably the most, I think the best part about being an OT is when you do have someone like George come back and he is really using all these things and noticing and verbalizing all these improvements that he's having with just maybe some simple education I was giving him, home exercise program, the therapeutic use of self that I was talking about earlier. He just kind of needs a coach, someone to support him a little bit. And he can kind of work through a lot of the things himself. So it's really when you kind of have that moment where you're goals met, where you're helping them to feel like they are truly engaged in what is meaningful for them.
There's a question here asking, have you been using any telehealth kind of appointments for follow-ups for patients?
Oh, no, but it is a good idea, especially him too, because I think as I go down my plan of care, he's someone that's going to not need me as much, given that he's just so good at kind of modifying what he might need. But I think given the nature of his diagnosis, it might be good to kind of have some virtual check-ins, because it's obviously a little bit more easier. But I haven't been able to or dive into that yet, but that's a great idea.
Great. And I have just one more question here, just again, kind of what is, there's a lot of different avenues that you can go into with occupational therapy. And so what brought you to the cancer space, and why did you decide to focus on that?
That's another good question. I think all good things, sometimes you don't know. But I think for me, I started off doing the fellowship on the inpatient side. And what that looks like is you're basically rotating all the different services. So, you'll see everything. But I think what really got me maybe in cancer is when I was actually on that floor, on that service, there was, again, this holistic nature of everything that I think you kind of alluded to well with the whole spectrum, there's just so much involved. There's so much that you can do. And I think there's so much that you can help with. And I felt like even small things like helping someone to brush their teeth someday when they didn't even think that they could get out of bed, like that's something that I feel like just helping people with the little things has been, truly rewarding, and has kept me in the cancer section, I guess. But that's kind of how I found myself here. And I think it also has, you're constantly learning, there's always new treatments, there's always new novelties that they're coming up with, but also with that new kind of things that are popping up that might affect someone that they wouldn't necessarily anticipate. So it's kept me creative as well.
Great. I have a message here from Dr. Lee saying, seems like this is maybe an underutilized resource for many patients and families. So we're just so thrilled to have you on today to really go into occupational therapy and why it can be such a great resource for so many cancer patients. So I don't see any other questions in the chat. We've only got a few more minutes left. So thank you so much, Kate, for joining us today and sharing your wisdom. We really appreciate you being here, and thank you again.